Hello, good morning. Good morning. Can you hear me?
Yes, sir. Good morning.
Good morning, sir. We can hear.
Yeah. Can you please put the slides up? Can the monitor upload the slides, please? I have sent the slides. You have got it now?
Yes, sir. I'll put it up.
Right. So today we are going to talk about upper GI bleeding. So this is again a very, very important topic because it's a very common thing. One of the commonest medical emergencies definitely in GI, and definitely a common emergency in ragam. So that's why it's very important to manage it, because ragam is called ragama for a reason. Right. So as I said, it's a commonest GI emergency. The incidence is about 100 per 100,000 in UK, and a mortality of 10% in the UK, but that has come down now. Varices is the commonest cause in Sri Lanka. Studies done here. But peptic ulcer, malariasis, esophagitis, gastritis, erosions, vascular anomalies,
Sir, shall I allow remote access so you can change the slides?
can we go to the next slide, please? Sorry, I got muted. Right. Okay. So this Rockall score, there is Glasgow score as well, not coma score. But so these are scoring systems which are used to triage the patient. So you don't need to remember this, but you have to know that there is a system like this which can be used. So for instance, if the patient is young, there is no shock, no comorbidities, the diagnosis is malady wise, and there is no stigmata of a bleed, right? Then the score is 0, and obviously the patient has a good prognosis, right? But on the other side, if the patient has renal disease, then cardiac disease, then the score will be high, and the outcome will be poor, right? So that is important, right? Just to know, you don't need to know the score per se, but you should know that there is a scoring system like that. Next one. All right. So Glasgow Blatchford score. That's the other score. That also can be used, and it's administered before endoscopy. Next. So this is the flow chart we use when a patient comes with bleeding. Very important. So is it a minor bleed? The best thing for your level is all bleeds you admit the patient, right? Don't send bleeds home, because till you do an endoscopy, you don't know actually, right? So you admit, you observe and do endoscopy with some minor bleed. If it's a major bleed, you have to resuscitate the patient. So that is very, very important. We'll discuss the resuscitation. Then only you must do endoscopy. You don't do endoscopy without resuscitating a patient. So on endoscopy, is there varices? Then it's banding and medical treatment. If it's non-variceal, when you look, is there no stigmata of a bleed? Example, are there clots? Are there ulcer covering the clot? There is no stigmata there, you can observe. If there are stigmata of a bleed, then you have to give therapy. Endotherapy plus PPI, IV. Failing which, you can go for either surgery, or you can do what's known as a mesenteric angiogram and block the artery that is supplying the vessel, right? So that also fails, you can go for surgery, right? Next slide. Right, so resuscitation, that's important. A, B, C, D, E. History. This is about that's very, very important. Even for the acute management, for a bleed, the history is very important. Sometimes the patient may be unconscious. Sometimes if the patient is conscious, you can ask the patient. So was the onset abrupt? Was there melena? Was there alcohol history? Was it fresh blood? If it's fresh blood, it's more likely from the esophagus, right? It is altered blood, it's more likely from the stomach. Having said that, if there is a huge bleed, massive bleed, then you can get something called hematochezia, right? Hematochezia is the passage of red fresh blood per rectum due to an upper GI cause. Right? It's important. Normally, bleeding PR, fresh blood from the rectum means it's from the left side of the colon. However, if you have bleeding like this, fresh blood, then of course it is called hematochezia. That means it's a very serious condition. So then examination is important. There's shock, liver disease, hemangiomas, and you have to do all this at the same time. Next one. So then examination, and you have to do all this at the IV fluids. Uh, there is an echo, no? Right. IV fluids. So, depending on the pressure, either crystalloids or colloids. Uh, then blood, keep the edge. Now, this is another important point. You must not over transfuse. They have done randomized trials to show that if you over transfuse, that means in a patient due to an upper GI bleed who doesn't have ischemic heart disease, the target HB is 8, not 10. Right? He has ischemic heart disease, then you can go up to 9 to 10. But otherwise, the target HB is 8. They have found why? Because if you over transfuse, they bleed more. Right? So if you try to target to 9, they bleed more because the varices fill up and then because of pressure, they bleed more. So generally you should keep about 4 to 6 pints ready, but depending on the HB only, you don't over transfuse. So that's the number one point to remember, which is fairly new, right? Evidence based. Then if the platelet count is below 60,000, you can transfuse platelets. And FFP, the PT is more than 17. Then important to monitor pulse BP, and if it's a large bleed, generally in the guidelines they say to put a CVP line in, but we don't routinely do that in our setup. Right? Then the next is endoscopy. So here the important thing about endoscopy is after resuscitation, that is the important thing. Don't just drag patients for endoscopy and have them arrested at the endoscopy unit, because that will cause more problems, right? Then experience within 24 hours is ideal, 12 hours is ideal, better, but less than 12 hours is not necessary. Right? They have shown that that is a problem, right? So definitely within 24 hours you should do that. The experience of the endoscopist is very, very important. You can't have a person who has just learned endoscopy handling a GI bleed. It is difficult, right? So then nasal prongs, oxygen, monitor, pulse, BP and saturation. Next one. So varices can be classified as small or large, and whether they have red spots or wales, right? So small is less than 5 millimeters, large is more than 5 millimeters, and red spots is important because if you have large varices and red spots, you are more likely to bleed. Next one. Yeah, this is the varices shown here. Right. So remember again, medical therapy, endoscopy therapy, right? Medical therapy first. IV terlipressin. You don't need to know the doses, but just the drug and how it's given, right? IV terlipressin, 2 milligram bolus, then 1 milligram 6 hours, 48 hours. It is not the only drug. Again, you have to remember this point. Only drug to affect mortality now. Somatostatin and octreotide also has a mortality benefit. Remember that. You get an MCQ. What are the drugs that affect mortality in bleeding from varices? Terlipressin, somatostatin, octreotide. All three have a mortality benefit. Vasopressin, of course, doesn't have, and it shouldn't be used for variceal bleed anymore, right? So that octreotide is for 5 days, somatostatin for 5 days, and terlipressin is for 48 hours. So these are all evidence from trials, right? That's why it's there. Next. So terlipressin is as good as sclerotherapy and has less side effects and mortality. That is the first trial that showed that. Then there are other trials to show that this somatostatin and octreotide are also now proven to be as good as terlipressin, right? Then, so vasopressin shouldn't be used in variceal bleed anymore, right? Next one. So now that is the medical treatment. Next, we have to go on to the endoscopic treatment, right? Endoscopic treatment is banding, right? No sclerotherapy, forget about it, right? So glue injection. Now remember, when you come to the final year, you can see all this in our endoscopy room, right? Glue injection, cyanoacrylate glue is used for gastric varices only, not for esophageal varices, right? So combination therapy, that is medical and endoscopic, is better than either alone. That again makes sense, right? So remember that. So, endoscopic treatment is banding for esophageal varices, glue for gastric varices. ඒක මතක තියාගත්තා නම් හරි. Right. This you see a picture of banding, but that's not working. So we go to the next slide. Right. So combination of medical therapy. I have just to ask you all, have any of you all seen banding? Or all of you all have seen?
Some groups.
All right. Okay. But remember, you can always see it here for real. There are so many YouTube videos which you can watch for banding, right? So banding is important. It's done all over now, right? So, and it's a standard therapy. So combination of either medical and endoscopic therapy is better than either. Banding is better than sclerotherapy. Those are the trials. And combining banding and sclerotherapy has no benefit, right? Next one. So this again is important. Concomitant therapy, right? What else will you give? IV third generation cephalosporin that has a mortality benefit. Remember that. Again, another MCQ. So omeprazole, if it is a pure variceal bleed, it has no place, right? Alcohol withdrawal, you have to treat, right? Thiamine, IV thiamine, nutritional support. Because most of these patients, especially in our setting, are alcohol dependent patients who may be on, maybe have been drinking and then had hematemesis. So you have to manage that part as well. But remember, so mortality benefit, terlipressin, somatostatin, octreotide, ceftriaxone, right? Not only ceftriaxone, any antibiotic, IV antibiotic, third generation. Next one. What happens if bleeding continues, right? So that is 2 or more uncontrolled episodes of bleeding. So I'll talk about factor 7 last, but Sengstake Blakemore tube, again available in Ragama. You can have a look at that. Or you can use tips. So tips, especially if it's child's A and B, you can use tips. Surgery, of course, is very, very unlikely. Transplantation is available. Obviously, that won't be the immediate treatment. But especially if you do tips is a bridge, right? So we have all these options available. Factor 7, activated factor 7 is expensive. It doesn't work in large trials. Next one. Yeah, so easy to administer, difficult to afford, very expensive. And no, it was shown to help in small trials, but larger trials didn't show any benefit. So we won't use it, right? No guideline, new guidelines don't support that. What about Sengstaken tube? Yes, you need that to buy time for tips, and maximum is to keep it for 24 hours. Right? So tips: transjugular, intrahepatic, systemic shunt. Right? You can see that transjugular, intrahepatic, portosystemic shunt. Right? So it's self-explanatory. As soon as you do that, the portal pressure drops because you're having a shunt between the portal and the systemic pressure. So you're actually creating some degree of hepatic encephalopathy immediately. So that's why it's a bridge to transplant. So without having transplant, no point doing tips because then the patient will be in encephalopathy and it will be difficult to handle. So in our setup in Ragama, we do have transplant facilities. So this is available, so we use that. Tips is available, right? So it's important for you all, I tell the final years as well, to see the things that are available in Ragama. Certain things are not available in Ragama. Eva හොයගෙන ඒව ගැන හිතලා දුක් වෙනවට වැඩිය තියෙන ඒවා ගැන පොඩ්ඩක් උනන්දු වෙලා ඒක බලන්න. Next one. So surgery, non-selective esophageal transection or Sigura procedure. No, you can do a distal renal shunt. No, almost never done now, right? So surgery option has gone out of this. Next. So long term, what do you do? So you ban the patient about 6 weekly, right? 6 weekly till the varices are obliterated. Then every 2 years, 1 to 2 years, you have to do surveillance, right? Very important to put the patient on a beta blocker, right? Non-selective beta blocker, either propranolol or carvedilol, right? Carvedilol has a slight advantage in primary prophylaxis and secondary prophylaxis propranolol, but for your level, either is okay, right? Either is okay. Carvedilol is alpha 1, beta 1, both it blocks, right? So propranolol is a beta blocker, non-selective. So it's important to have a non-selective beta blocker. You can use nadolol as well. Nadolol is not available here, but propranolol and cardiolol is what we use. Carvedilol. So long term, that's very important to put the patient on that. If the patient has contraindications for beta blockers, for instance, bronchial asthma, then there is an issue. So then you have to only go with banding procedures to eradicate the varices. Next one. What about primary prophylaxis? So that is, you have cirrhosis, but you don't have varices, right? So if it's more than, if it's actually there is no place for nitrates. So that primary prophylaxis, you have varices and you have not bled. So then you definitely Either if it's large varices, you can ban the patient. If it's small varices, you can give propranolol or carvedilol. Right? You don't use nitrates anymore. So banding is probably better than propranolol in large varices, especially if there are red spots. Right? But otherwise, you will go for propranolol or carvedilol. Next one. Before I get on to gastric varices, remember, so primary prophylaxis, secondary prophylaxis, both either carvedilol or propranolol. Pre-primary prophylaxis, that means you have cirrhosis but no varices at the moment, nothing. So these are gastric fundal varices. Again, there is something called a serum classification. You don't need to know that. But what you need to know is the treatment here is different to esophageal varices. Right? Next one. Yeah. So treatment of gastric varices, cyanoacrylate blue is what we use. There is intravaricial thrombin. BRTO is balloon occluded retrograde transvenous obliteration. That's not done here routinely, but it's done in other parts, started in Japan, where you go and obstruct the sphenic vein and then you inject the varices so that it blocks it. Right? So that is supposed to be an very effective method, but again, it's a combination of radiology and endoscopy, so it's a complicated thing. It's not done here at the moment. Right? Next one. So before we go on to peptic ulcer disease, I want you to, because upper GI hemorrhage is a very important thing, I want you to, if you have any questions or doubts about the management, they're very, very common. It's asked in vivas, it will be asked in your long case, right? MCQs. ඉතින් මේක හොඳටම දැනගන්න ඕන. In and out දනින්න. මොනවා හරි doubts තියෙනවා නම් මේක clear that.
Sir, regarding esophageal varices,
Yes.
how often should you do the banding?
Yeah, sorry, that is that you generally 6 weekly, 6, not 3 weekly, 6 weekly, because if you do it 3 weekly, sometimes the erosions are there. Because when you put bands, they heal with fibrosis. That's the idea. So sometimes you get banding ulcers, and if you bleed too early, it's difficult. So generally, consensus is about 6 weeks, just more than a month.
Okay, sir. Thank you.
So another question. About the endoscopy, what is meant by the nasal probe? So are we keeping them under oxygen while doing endoscopy?
Yes, because you have to give oxygen, so you can't give a face mask. So you have to give nasal prongs. You have seen the nasal prongs, because normally you can give oxygen either via face mask or you can via nasal prong, right? So face mask then because you're doing endoscopy from the mouth. That's why you give nasal prong.
So what is done in the sclerotherapy?
Yes. What do you want to know?
What is sclerotherapy?
Yeah, sclerotherapy is like for when you have varicose veins in your leg. It's called STD, sodium tetradecyl sulfate, which is injected. It causes like immediate fibrosis of the thing. That was a very old technique used for injection of varices, right? Now that's not used at all, so you can forget about that. For your level, you don't need to know that. Just think of banding, that's all.
Okay, thank you.
Sir,
Yeah.
for pre-primary prophylaxis, the cirrhotic patients with no varices also, beta blockers, are they given to them?
It's not standard therapy because for your level, remember, it's not effective, right? Maybe in the future there will be trials. There are some trials coming through that it may be effective, but at the moment it's not in the guideline. So remember, pre-primary, that means cirrhosis, no varices,
Yeah.
you don't give.
Okay.
Primary prophylaxis you give, secondary prophylaxis you give.
Okay, sir. Right. Thank you.
Right. Right. Okay. Then we start about peptic ulcer. So, peptic ulcer bleed ulcer, again, you can do either the Rockwell when the patient comes or the Glasgow Blatchford score, right? But this is an endoscopic classification called first classification. Again, you don't need to know this, right? But just that's to see how severe this is. So the worst situation, 1A, is when you see a spurting artery. Right? Though it's the worst situation, in a way, it's a good situation. And then you can see the bleed and you can treat it immediately. But of course, it is not for the faint-hearted, right? Then, so that is 1A. So then 2A is you can see the arteriole, right? And there are different A, B, and C. Then the other one there is adherent clot, and third one is the ideal thing. You can see the ulcer, but there is a clear base, right? Clear base, nothing, no clots, nothing. So that is the best. That ulcer will not bleed again. Fairly certain that it won't bleed, right? But the others can re-bleed. So you have to do some therapy, right? That's the idea of this classification. You don't need to know it, but you need to be aware of it. So next one. So again, now treatment, there is medical and there is endoscopic, right? අරකෙත් ඒ වගේ තිබුණේ medical තියෙනවා endoscopic තියෙනවා. If you're answering a question also, always answer like that. There is medical treatment, there is endoscopic treatment, right? And it's easy to remember. So endoscopy, adrenaline, 1 in 10,000 you inject 10 ml or whatever around the ulcer, right? That immediately stops the bleeding, right? But that is a temporary measure. You have to combine it with something else, right? So then the other medical treatment will be IV omeprazole, 80 milligram bolus and 8 milligrams per hour for 72 hours. Why 72 hours? That is from the trial, right? So because of trial, we are following evidence-based medicine only, we do that, right? Repeat endoscopy can be done once, otherwise surgery and Helicobacter pylori eradication is important. We spoke about that yesterday also, right? Next one. So what are the endoscopic therapy methods? We discussed adrenaline, which is cheapest. That's what I'm showing in the first picture. Cheapest one available, right? Then you can get clips, right? And clips. Then you can put a wire loop. Then you can do heater probe. Then you can do APC, argon plasma coagulation. So all those types of things are available, right? We have all that in Ragama, right? All these things, we have the APC, we have the heater probe, we have the clips, fire loop, everything is available here, right? So when you come to your final year, you can come and have a look in the endoscopy room. All these are available, right? So we don't do generally on the list, we have used these procedures. So there are so many types of clips and all that. So what's important is, always, if you are using, we generally use adrenaline, but with adrenaline, you must always combine something, right? You can straight away go for clips or any other method, that's okay, but whatever you're comfortable with, you can use. Next one. So, right. So, again, to summarize, GI bleeding is a medical emergency and should be treated like that. Proper resuscitation is essential, right? You have to resuscitate the patient, and early endoscopy is important, right? So, within 24 hours. Banding is superior endoscopic treatment, while terlipressin, octreotide is the best medical treatment, right? Combination is better than either alone, right? And antibiotics for 7 days, IV antibiotics, and vasopressors for 5 days. These are in varices. Then also remember primary prophylaxis, either banding or propranolol, carvedilol, nadolol. Secondary prophylaxis, yes, you use the carvedilol or propranolol or nadolol, right? And you ban the patient as well every 6 weeks, right? That is long term. If it is in ulcer, medical, IV omeprazole infusion, 80 milligram bolus, 8 milligrams per hour for 72 hours. Endoscopic therapy, you can use adrenaline, you can use clips, you can use wire loops, heater probe, APC, argon plasma coagulation, so many things. If you use adrenaline, you don't use it alone, you combine it with another method, always, right? And remember, we spoke yesterday, it's a gastric ulcer. Later, when it's bleeding, you don't biopsy a gastric ulcer. Later, you must biopsy it to see whether it's a carcinoma. And if H. pylori is positive, you have to eradicate H. pylori. That we discussed yesterday. Triple therapy for 14 days. Right? Okay, now any questions? Because I have kept it very simple, because you can complicate this, but any subject you can complicate. But if you know this much, that's more than enough for you, right? But have this clear view. This is asked all over, right? It will be asked all over, including your final year viva. Right? Any questions? Clear?
Yes, sir.
Right. Okay. Right. Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.